Yes, thank you very much. My talk today is going to focus on a somewhat personal perspective of the logistical implications in clinical practice of these novel ARV compounds and the new delivery devices. These are my conflicts of interest. The first aspect I would like to talk about is the issue of long-acting oral compounds. Islatravir is currently under investigation, a drug that has the potential to be given once weekly. The problem in logistical terms could be that if this is not combined with other drugs that are given at the same interval, it might lead to problems in adherence counseling, and it might actually at the end be more difficult for patients to take it regularly than a whole regimen that is taken at the same time interval. So that's something we have to be alerted to. And what we don't know exactly is the flexibility of the time points, because we have to ensure adequate drug levels at any time point, and delaying drug intake because simply people forgot or something else kept them away from taking the drugs could lead to problems in terms of drug levels. This is an issue especially for adherence counseling. Ibalizumab has already been licensed for use as a short-acting intravenous drug. As said, its application mode is intravenous, and this means that it requires some time for preparation by staff of pharmacy. We need to ensure enough time and personnel for venipuncture and infusion over 30 minutes at the first time point and 15 minutes at subsequent ones, if everything's well tolerated, in a sitting or lying position. So we need facilities for that. We have to ensure side effect monitoring over 1 hour post-infusion, and we also have to document the lot number according to law. Medication storage has to be logistically organized. Should it be on site in the pharmacy, or may patients even take the drugs home, which would raise the issue of the cold chain, and the drug has to be warmed up before infusion. It's only stable for 4 hours at room temperature and 24 hours in the fridge. So what happens if the patient doesn't come to the visit? We might have to discard a very, very expensive drug without ever having seen the patient for that. The dosing interval is not very patient-friendly and not very logistics-friendly because it's every other week following a loading dose. And there is very little flexibility about this. We can delay it by only 3 days and would have to reapply the loading dose again if this goes over 3 days. That raises the issue that we have much more frequent visits than usually with oral treatment. The one thing we know most about is long-acting intramuscular applications of cabotegravir and rilpivirine. That's already licensed. As said, it's being applied intramuscularly, and that requires enough trained staff. It requires an availability of a separate room for injection due to privacy, a bed or a couch for injection. We have to record the site of drug injection because we have to use the same site for the same drug, preferably all the time. And it might be difficult sometimes if people simultaneously have to be treated for syphilis or gonorrhea to inject penicillin or ceftriaxone at the same time point. It may be done, but people might not tolerate that very well and might have to show up for yet another visit. Waiting times are somewhat a problem because of these logistics during the SARS coronavirus epidemic. We need to ensure that there are minimal waiting times in crowded areas. If the patients are ART naive, it has to be ensured that there is a full suppression before switching to the injectables, optionally introduced by an oral lead-in phase with counseling about possible drug-drug interactions with rilpivirine. But that might require a deviation from our usually monitoring policy. Medication storage has to be organized, again, on-site in the pharmacy or patients at home, but that again raises the issue of rilpivirine cool chain. The drug also has to be warmed up before injection for about, according to our experience, for about 20 to maximum 30 minutes. And again, the question is, what if people don't come? So actually for both of the drugs, evolizumab and these two drugs, intramuscular drugs, we probably can just start preparing the drugs when the patients are already on site. So this probably will lead to some waiting time. The dosing intervals are also not very patient-friendly. In the US, it has to be injected every 4 weeks. In Europe, 8 weeks will be allowed. But the flexibility in any case is only 7 days. So if people get stuck somewhere, cannot show up for their injections, we need to make sure that they have oral drugs to bridge this decreased exposure to a maximum of 8 weeks. And also that means for the patients that they have much more frequent clinic visits and possibly also viral load monitoring, because we know there is some resistance in these clinical studies, and we might not leave this undetected for a longer time. So that would mean maybe changing our policy of measuring viral load. And that's much more frequent than with oral treatment. And treatment interruption has to be avoided because of the long half-life of the drugs. We need to ensure also that people have adequate coverage with ART for the next year following the injections. The next mode of administration I'd like to cover is long-acting subcutaneous drugs. We have a prototype for that, lenacapavir, which is currently in clinical trials with some favorable results already. This compound reaches its suppressive levels a little later, so we need an oral lead-in, which requires patients to wait for the subcutaneous injection until they've actually reached sufficient drug levels by oral lead-in. And we have to organize this with the patients and call them in, and probably have to give the first injections under supervision. It's administered subcutaneously, so we have to educate patients to do that properly. We have to see how medication is stored at our sites. Is going to be stored on site in the pharmacy or given to the patient to take it home. What if the patients don't come? Will we have to discard some dosages? Doesn't appear like that, but that's still not totally clear. The dosage interval of 6 months sounds very interesting to patients, but we don't know right now how flexible we would be in terms of delaying this dose and adapting it to the living habits of the patients, possible vacation patients are on, for example. The long half-life, like with cabotegravir and rilpivirine, requires, in my view, very similarly, that we have to keep patients covered with a fully suppressive regimen if treatment has to be interrupted or discontinued, as resistance has already been described after short-term exposure. There are a lot of other suggested modes of delivery, and as you can see in the column drugs, most of the drugs proposed for these modes of delivery are drugs we already know. The ultra-long-acting biodegradable polymers could actually be interesting because they could be administered up to once yearly, again raising the similar issues of forgiveness at the second time point if visits are missed. And also, they don't appear to be removable. So if we have intolerance, if we have lack of effect, we'll have continued exposure for a very long time. This could be different with the drug-eluting implants that could potentially be removed. So we could then switch to something else and not risk exposure at decreasing drug levels with resistance. The microneedle patch application might be very interesting because that can be applied, probably be applied by the patients themselves, but we don't really know the issues associated with the logistics, for example, heat stability and all this, especially for tropical countries. And also, the last mode is very interesting from an academic point of view, the oral drug delivery system that is applied weekly in the stomach. that releases drugs slowly. That's been applied in a pig experiment, but we really don't know if this is ever going to make it to clinical trials or the clinic, and we don't know about the logistical implications of that. So I think the experimental and therapeutic potential of these modes of delivery is still unclear, and adherence over long time frames might actually be more challenging than an oral drug applied daily. And the logistical problems are really hard to foresee. My take-home message would be that we will have to counsel patients very intensively, give them detailed information and written information, and also provide access to electronic resources where they can always briefly look up if they have problems, and emergency contacts before even starting. The other physicians involved should be informed, and they should know about possible drug-drug interactions. This especially affects rilpivirine among the drugs that are now applied in these novel ways. And, for example, the bleeding risk with anticoagulants in case of intramuscular injection. Because what we had, for example, sometimes that when people were put on oral anticoagulants because of coronary heart disease, and we got to know this weeks later. And if the injection is actually just continued without any clinical control of this, of the co-medication, this might lead to problems. We have to ensure that we have enough dedicated and well-educated staff and sufficient facilities for administration. I think I'm just reiterating that. Privacy should be ensured. We can't simply inject intramuscularly somewhere in the clinic with other people watching them. Reminder systems should be in place. We, I think, preferably should use electronic reminder systems, but some people do not have smartphones. Some people are not familiar with this. So we have to also have phone calls and actively trace people, probably also triggered by reminder systems for the clinic staff. Our experience from the clinical trials is that people tend to not show up at the right time point, tend to forget, sleep over in the morning. So we very actively have to check if they've actually shown up and call them. And sometimes it's possible for them to come in the same day so that we can still apply the drugs within the time frame in which they can be applied. Longer waiting times, as I said, should be avoided in times of SARS coronavirus 2. For islatravir, as an oral drug, I would actually suggest electronic reminder systems. If it's combined with QD drugs, we need to have this for each drug in order to ensure that patients are not underexposed by any of the drugs at any time point. For the injectables, I think in view of the inevitable waiting times, there have to be low barriers for appointment booking, and we probably should ensure appointments outside of regular working hours. Ibalizumab has to be prepared. We need to deliver it, so that's going to mean some time, some waiting time for the patients, and we need to ensure that the logistics of preparation and delivery within our units is established. As I said, and I'm reiterating that this again, we need sufficient staff and time for venipuncture, infusion, and monitoring. And for cabotegravir rilpivirine, as I mentioned, we need the bridging medication. I think we need it to take home for the patients because they might run into the situation or not being able to come, and if they don't have anything at home, they might not be able to start the oral bridging. Sometimes still, we might have to send this by courier. That happened to us when patients were actually abroad and got stuck in another country during the SARS coronavirus epidemic. We had to send it to them via courier. So all of this has to be kept in view by the staff proactively. We need enough waiting room and injection facilities. I said that already. But maybe in some settings, it would be possible to arrange home injections by specialized nurses. ART after discontinuation has to be ensured upfront, I think. So in Some countries where people, for example, are illegal or have an insecure status, they might not have insurance coverage. So for the time after discontinuation, for example, of cabotegravir, we need to ensure that they actually have adequate supply of antiretrovirals to avoid exposure to the drugs at suboptimal levels and risk resistance development. And I also think that we have to think about how to adjust HIV RNA monitoring to the risk of treatment failure. We know that cabotegravir may lead to some cases of resistance. That was uniformly the case in all of the trials. So we need to ensure that we don't miss early failure in order to prevent rapid progression of resistance development. Would be preferable to discover this very early. And that might mean for us to change our schedule of HIV RNA monitoring and blood sampling. So my summary would be that the novel parenteral and to a lesser extent even the oral antiretrovirals, the long-acting ones, pose new logistical challenges to patients, HIV treating physicians, and clinic staff. Some of these challenges are similar, for example, the adherence management or PK characteristics of long-acting drugs. Others are more specific for the mode of delivery and the drugs used. They will likely require additional dedicated and trained staff and adequate facilities. These novel modes of delivery require a proactive approach with active tracing of patients in order to avoid treatment failure with resistance. That would subsequently limit the patient's chances of sustaining HIV replication up to their natural lifespan. Sites should prepare well in advance and implement the necessary logistics and think through all the different steps from presentation of the patient to actual delivery of the drug to the patient. And these logistical challenges, and I'm talking a lot about cabotegravir because that's the one thing we can use for routine of the long-acting injectable drugs, will likely limit the number of patients substantially in most settings. Thank you very much.